get out the video.
That I just wanted to address with y'all as a group, and I want you to encourage you to ask any questions that you may have. So the first thing that is really important to us in the rooms is thermoregulation, right? So we've got to keep the trauma patients warm. If it's raining outside, they've been drenched in rain, they come in cold, right? So you're not necessarily just losing heat from like a normal body temperature. They may already come in cold. There may be a period of time that they're undressed in the trauma bay. You're already sort of behind the 8 ball. So let me ask you guys, what are some measures that we can employ in the operating room so that our patients don't sort of continue to lose heat? Anybody? Keep their room warm. So what do you want to set the room at?
Usually it's 70, 72.
Okay, you can even jack it up to 80. Your surgeon's going to complain at you, and they're going to be like, oh, I'm sweating or whatever, but, you know, you sort of do what you have to do. Now, if your patient is euthermic, right, is at normal temperature, you don't have to jack it up that high. Not everybody has to be miserable in the room. But if your patient comes in, you put in the Foley, you check the temp probe, and it's like their temperature is 95, the temperature's got to go up. So it's just something we have to be cognizant of. The colder they are, the more blood they lose. What are some other things we can do in addition to room temperature? Bear hugger, right? So that can be difficult in trauma, right? Depending on how much of the patient needs to be exposed. On real, like big trauma cases, you're exposed from here to the knees. I mean, you can put them on their calves, but you know, whatever. If it's strictly a belly case, then certainly an upper or lower bear hugger is great. What else?
So they decided to do an under body warmer. Actually, the fluid one. That was from Dr. Pillay in Melton.
Okay.
That's what we're going to do moving forward. It's
Okay.
under body warmer.
Where are they?
Flight control. There's 2 in the supply closet, and the warmers are on the thoracic aisle, top shelf. And there's also a head warmer too. I mean, you know, not that you need that, but they're both.
So yeah, I'd like to encourage you to, use the underbody as much as possible, especially if it's a big trauma case where the person has to be sort of more exposed than not. I have stapled things to the underbody warmer, and then you feel like an ass because your patient gets wet and then they get cold again. So don't be me, don't staple stuff to the underbody warmer. Any questions about thermoregulation or things we need to do for trauma patients?
What's the name of that machine they said?
Flight control.
Nothing? No? Okay, moving on. TAG. So if your surgeon asks for a TAG or your APP asks for a TAG, do you guys know what to do?
No.
Okay, excellent. Do you guys know what top it goes in?
Green too.
It goes in a blue top.
Blue top.
It goes in a blue top. And then, pardon?
What is tech?
So, okay, so that's a great question. So, back before TAG, what we used to do to see how coagulopathic a patient was is we'd just take their blood, put it in a blue top, also send it to the lab, and we'd get a PT, INR, PTT. But they noticed in trauma that that's not always completely accurate. And so what a TAG is a machine that literally takes a little blood and puts it on this rotating thing and sees how quickly a clot forms, how strong the clot is, and how quickly it begins to break apart. It's really useful because based on the different measurements of TAG, will tell us exactly what product we need to give. Oh, this is a little bit long, we need to give FFP. Oh, this is too short, we need to give platelets. So it's really useful for us. The hospital also invested a lot of money, so it really wants us to use it. But it's also got the added benefit of actually being useful.
Where is it?
Pardon?
We don't keep it. We have to send out to the lab.
You send it to the lab, and this is key. So when you put in the order, and I don't know if you can send out, I can send you an email maybe to send out to people. We need to order a rapid citrated TAG. And that's the order that you put into the lab so that they know how to run the blue top.
Are you saying TEG, tech?
TAG. TEG.
Rapid citrate.
Blue top. Blue top.
Rapid citrated TAG. It's a thromboelastogram, which is literally like, they're just playing with the clot and sort of seeing what it does. But I will send out an email that we can sort of circulate so that people can sort of see it written down. And any other questions about TAG?
Is it possible to create a trauma bundle where we can find, for example, this test, a MTP or so we can just quickly click on the trauma bundle, click on the tag or MTP or all of the above and just go to make it easier on us instead of having to look for all of these tests individually.
Yeah, I think that's a really good idea. We can absolutely do that. You have to let me know what else you would like, and we'll brainstorm on our end to see what else there is in there.
Yeah, they would have to get with you about what other tests that you might want.
Yeah,
to-
I don't know what else, other than standard labs and a tag, we don't usually put in a physical order for MTP. I don't know if they're giving you a hard time when you call for it.
No,
I think they do it. I think
Yeah.
blood bank does it on
Puts
the
in the order for
NTP.
MTP.
Yes, I've never had issues with that.
Okay,
You call, they just send it right up.
and I will brainstorm on my end as to what to put in a trauma bundle, but if you guys have other things that you're like, man, during that trauma case, I could not find the order for X, and let me know. Like, again, we'll put together a thing, but then look at it if you can from your end and let me know, like, it would be useful if we had this as well. Okay?
Thank you.
Chest tube, the Pluravac. So you guys have heard, as much as possible, if you guys can monitor how much is coming out of the Pluravac. Are you guys comfortable with that, or is there a place that we can put it so that it's more convenient for y'all to check it during the case? Everyone's just staring at me.
Well, ideally, don't, during the case, we're doing at 500 other things, so monitoring the output of the system is not going to.
Yeah, the issue is, and I hear you, and I see how hard people are working during trauma cases. I don't think anybody's like on their phone playing Sudoku or anything like that. I think the issue is that if it's like a critical trauma case, anesthesia is pouring in MTP or doing whatever, we're operating, so we can't check it, it's under the table. And so I don't know if you need to call somebody additional in, or, I mean, I know that's also difficult, and so I want to talk to you about a possible solution. It's something we need monitored, because, for example, if you have somebody with a gunshot wound to the chest that migrates to the belly, I'm operating in the belly, but I put a chest tube in the chest. If it starts dumping out, I need to know I need to go into that chest. And I don't have any way of looking at it. And so that's sort of where we're coming from with that. So is there something that we can do to sort of help facilitate that? Because that's something that I don't want to get missed during trauma cases.
I have a question. So normally, doesn't anesthesia monitor all the output, like Foley output? So why are they not monitoring the chest output as well?
So they do monitor urine output.
I mean, it's all going down, and we can also put it up. It's whatever, wherever they want it, so they can look at it.
Yeah, so I
But
think-
they document and monitor that.
Yes, my understanding is that during a critical trauma case, if they're the only ones pouring in MTP, they're not gonna be able to do it. And so, again, I think we can not necessarily absolve them completely of the responsibility of looking at it, but it can't be, this is anesthesia's job, or it's by the surgeon's feet, nobody
Oh,
can
it's not
see
that.
it.
I'm sure it's just
Yeah.
that we're used to in regular cases them monitoring all those things. So unless they verbalize to us, hey, I can't do that, can you just look at it for me? We're not doing it. That's probably why it's not being done.
Okay, I think, and I definitely hear where you're coming from. I think the issue is just, if you guys could just take a look at it and, again, and if it's a situation where we notice, from a surgeon's perspective, they're pouring in MTP, they're not going to, it's our job to then notify you. I guess what I would just say is, think about the patient and just be like, anesthesia may be monitoring it, but if I have a second, let me take a look at it and make sure anesthesia knows, oh, the canister's full after 20 minutes, or what have you. And not just say, this is anesthesia's job, I'm not gonna check it. Again, I don't think anybody's, I never see people just sitting around. But we just wanna make sure, because there was a patient that was missed on, and I think they bled out through their chest. So we're just trying to sort of make sure that we're employing sort of a belt and suspenders approach where multiple people sort of know to look for it. Okay, all right. In terms of NTP, you guys said that they usually put in the order for MTP, is that correct? The only other thing that I wanted to see if you had any questions about MTP, and then secondly, make sure that we're returning coolers, because we've had a run of situations where we're using MTP, we control the bleeding in the belly, and the cooler doesn't make it back to the blood bank, and then we have to trash all the blood that was not given, which is suboptimal. Any questions about it?
You usually just call the blood bank and say, I'm activating NTP, is that the process?
Yep. Yep, and then I guess they put the order in, I don't know, like magic blood appears to me, so I'm like super excited about it. I don't put in an order, but, yeah.
There are times when the blood will follow the patient upstairs. I mean, but that's.
Oh, to the ICU? Yeah, no, then it's not, as long as you look in the room after and you're not like, oh, there's a cooler here. And that's on us too. That happens down in the trauma bay, and that's our responsibility, but it's a huge resource that we're wasting to not have the blood. And so if you guys could like look around the room at the end of the case, and if you notice a cooler there, just call and say, I'm bringing this back. There's a fair amount of time that we have to get it back. It's packed with ice and everything, but as much as possible, we can make sure it's going back if there's anything left in the OR after the case. That would be awesome. And then the only other thing I have is we have an upcoming in-service for Roboa. Have you guys heard about this? Or
Yes, so that's actually coming next week. We've posted signs for the staff. They'll be here Monday, Tuesday, and Friday, because we're gonna be using this new product. It's new to us.
Yeah,
It's
yeah,
not
certainly.
actually new.
I mean, it's new-ish.
It's been
it's
around for like
newish.
50 years.
They were using it in the military, but this device is pretty new.
Yeah, and so we will have an in-service, the rep will be coming, and it'll be a better way to treat these patients that come in from the ED, that we need to crack their chest open, so that, it helps with infection and, you know, cross-clamping and things like that.
Yeah. The quick and dirty of Roboa is basically if somebody codes in front of you or is very hypotensive from like an abdominal or pelvic bleed, what we used to have to do is open the left chest, cross-clamp the aorta to get control. That's a lot. It's a lot to ask somebody to recover from if they make it through that. It also takes a minute, and in addition, people are usually like, you know, getting a little frantic, and like scalpels are flying, and there's a risk of people getting cut, like us. And so what was developed instead was basically this Roboa device. You go in through a femoral artery, and you put a balloon basically up the aorta, and you float up. And it occludes the aorta that way, and so it's sort of a neater thing than having to open somebody's chest. It's been used, I used it down at Grady. I think AMC has adopted it fairly recently, and so I thought we should bring it here and have it here. It's not something I anticipate sort of using all that often. We'll have a couple of boxes down in the ED. I think we're gonna store 2 up here. And so I just, you know, if y'all can come to the in-service if you have a free minute, that would be great. We can tell you all about it. We'll be handling, obviously, placement and monitoring and everything, but it'd be nice to just get your hands on it and sort of see
Do
what
you
we're talking
require
about.
C-arm?
Nope.
No, just cut down and go?
The only thing we may need is, so if somebody's coding, like truly coding, we put it in and inflate it without visualization. We base it on, we measure it first and see what level we're putting it at. But we don't have time to sort of get an x-ray and all of that. If somebody is hypotensive but not coding, what we'll frequently do is put it up, get an x-ray prior to inflation just to see where the markers are, and then inflate it. So we may need an x-ray depending on sort of how sick the patient is.
So then you would need to make sure you're in a sliding bed.
Yeah,
That was why I asked.
got it. Any questions about anything?
Yeah, so then do we have it, we have a standard, right? Which bed we use then? The versatile bed pretty much, or sliding bed?
I mean, so the same thing that you use to like make sure at the end of like a open abdomen case that you check an x-ray on is just what you need for this. It's literally an x-ray.
You could do a flat plate too, huh?
Yeah,
So
they
you
can
just
do
are
it
doing a
flat.
flat plate. It's
Yeah,
not sort of
it's
any
not
more
sealed.
involved than that.
Oh, right.
Yeah, you don't need like any of the special beds. We're not fancy like that. We just need to know sort of where the markers are. Because you don't always, to be frank, know when you're gonna need it. Somebody may look stable at the beginning of the case, you induce them, and then you need to deploy the device. All right, any questions or trauma, anything I can answer for you guys. So I will work on the bundle and getting that sort of order set together.
I know we talked about the underbody. Are we making it a standard to have it on our bed,
Yes,
ready to go? We
yes,
should.
yes,
If
I
we're,
agree.
if we're going towards that and we're gonna, if that's the thing we're gonna use.
Yes. Because that you can sort of plan for. If your trauma's coming, you can just slap it down on the bed, as opposed to getting somebody on the bed and finding out you can't cover much of them with the bear hugger, or the temperature in the room is cold and it's going to take a while to sort of heat it up.
So is that currently in the trauma room at night now?
Should live there, yeah.
Part
We
of the
need to,
equipment?
that's what I was getting at.
And one of
We
the
need to
blankets
have
should
it on
live in there.
There's
The
two,
blanket should
there's
be
two
on
in
the
the
table.
supply closet, Catherine. If you don't know how to use it, I'll show you how to use it. There's two in the supply closet.
Yeah, I haven't.
I can show you.
I think that we should have the blanket on the bed, and then once you get a call that the trauma is possibly coming, you can flip it on and set
Just
it.
get it warmed up and ready to go.